Is this true? Why? Because you have more tools in layering. You can create the depth. And given the same shape, obviously the layering will be slightly superior. Now, second question would be, which side is more expensive to do? Well, think of the prices of, acquisitions and all of that, and it's quite obvious that the digital will be the more expensive side, right? So can I safely conclude that if we work in digital the same way, with the same mindset that we do in analog, we pay more and we probably get a little bit less? Now, I know this is not the introduction you were hoping for in a digital lecture, but I think it's important we start from the truth. Because this is probably one of the reasons why after 30 years, the second richest field in medicine after pharmaceutical doesn't buy in a technology so powerful only to a margin of 5% around the world. That is the number of users around the world that use CAD/CAM. Why? Because it's expensive, you have a learning curve, and if you work in the same mindset, you get less. Above that, the patient doesn't care if you work digital or analog. I mean, if the work is bad, will the excuse of, yes, but I did it digitally save you? No. If the work is good, again, nobody cares. On top of that, there's something as from a business standpoint called transparent superiority, which means if two products are very similar, the one that costs more has a smaller margin because you cannot sell it for more expensive than the other one. So, above all this, what me and Eric will lecture today is why we still pursue digital on top of these arguments. Because what I just told you is a truth we all know. But beyond that, it's very important to understand the real reasons, the real powers in digital dentistry. It's not the cost, because if you want to work digital now, you have to buy a scanner, a printer, milling machine, all of these things. It's not the precision. Precision is more operator dependent than technique dependent. It's not even the speed. It's technically, I mean, if you take it, if you compare it in this kind of workflow. But on top of that, there are other arguments. And we will start combining. We will basically show the same things in analog. Eric will provide us with the analog cases because he can provide you with cases that have long follow-ups and experience. And I will then compare to what digital can do. Eric?
Yep. Okay. So, nice introduction. Very nice introduction. And first of all, I need to...
First of all, you need this.
Yes. And I need to thank Florin Lazarescu for inviting me. It's really an honor and a pleasure to be here. It's a very well organized meeting. I have to congratulate the organizers. For sure, it's very rare to see this amount of young people, I'm talking young people, young dentists, that are interested in seeing new things. I want to thank you also. Florin I met a long time ago, and from the beginning I thought he was a little bit different and special. And he came up with some digital ideas, and in the beginning I said, I'm not going to use it, I'm very happy with what I have. And basically when we started to use it, and he's right, there's many reasons why not to use it, and mainly the expenses and the things he just explained. But for me, the most important thing probably is that I am predictable from the start till the end. And that, for me, is very important. I've been working with the best technicians from Brazil, with the best technicians from Europe. I always get a nice result, but it's always like a secret how it's going to come back. If I may ask him to make a wax-up for the start to make a mock-up, and I get a second wax-up and I get the final crowns, is always different. So there is not any, let's say, predictability in the case. So what we thought is, let's go back in time. I graduated in '82, which is 35 years ago. We started with some plastic periodontal procedures already 30 years ago, combining with pros, with implants. I'm going to take you back in time and explain you what were my problems, because if I have these problems, many people in the room will have these problems. It's not that we cannot overcome the problems, it's just about very, very time-consuming and predictability. I think that's very, very important. So let's have a look at the first case. And basically, for the next 2 hours, we selected 5 cases. I think it's important to understand what's happening around with natural teeth. And if you understand this from all point of view, from prosthetic point of view, from surgical soft tissue management point of view, from digital point of view, you will understand what we are doing with implants. And basically what I asked Florin some time ago is, can you please try to integrate our analog concepts, the things that we have been doing for 20, 25, 30 years sometimes, would you be able to implement it into digital? Because for me, if I see a lecture and just some scan going around an arch, it doesn't mean anything. I need to be able to use my analog knowledge and my analog concepts in a digital environment, just to be more predictable. So let's have a look at the case. It's an old composite case. That's the first thing. And maybe Florin can comment a little bit on this also, because our big issues in the beginning in these full arch cases were, how are we going to give the reference of simple references to the dental technician? How are we going to transmit or transfer the horizontal line? Florin, explain me again, it's here. Yeah. How are we going to... You don't have just a pointer?
The big button.
Which big button? The black is forward.
This one.
Oh, that's forward.
Yeah.
No, the pointer.
The pointer is just this, the highlight.
Okay. No, I'm not going to use it. So horizontal, midline, vertical, horizontal, vertical. That's the only thing I wanted to transmit to the technician. Why did I want to transmit to the technician? Because mainly in these cases we were thinking we have to plan everything ahead. It's like the architect that built this building, he has like a design in his mind, he has a maquette eventually. And if you know this, you decide on your treatment plan. Of course, I can see I can do much better prosthetically. I will use some orthodontic treatment in the lower. We will have to do some soft tissue corrections, but how do we plan this? Imagine now you send the model like this to the technician. There is no reference. Your wax up will come back maybe like this or maybe like this. Maybe the midline will be like this, maybe like this. So it's a problem. The communication becomes a problem. If a very good technician makes a full arch wax up and it's not right from the start, it costs you a lot of money. One of the advantages of the digital for me is I can plan. It's on a computer screen. It's not really a wax up. I can get something back. I can Skype with Florin or with his team. Tell them I need it a little bit like this. Or it's very simple now to do it.
Just to comment here a little bit, I think that, you know, in the past we would diagnose and plan many times in real time by looking at the patient. And this, first of all, is hard to do and hard to transfer to the rest of the team. And what is happening since the very first digital dentistry, not just, you know, I'm not talking about STLs here, but even pictures, is the fact that you diagnose the data. So you're looking at the data, which is much easier to plan on, and the same planning is easily shareable to the rest of the team.
Yes, the sharing, yes, and I can send now something to Patagonia, it doesn't matter. Like imagine 3-4 years ago I had to fly in good technicians from Brazil every month. And now I can send a file. It's only 3 years in between. So we were using this, like placing a model on a picture, sending this picture to the dental technician. We've been using Ditramax from our friend from Marseille, from Patrice Margossian. The main thing is we were planning on the model. So we were designing, Murillo Calgaro was the technician, was designing the crown lengthening that I need to do. He was designing the midline. He was basically planning the case together with me. Now there's another thing, and that's something very important, I think. If you start to make a wax-up like on the right side, which was done 11, 10 years ago maybe, you have a problem, because this mock-up that will come from this wax-up is not the reality. And you will see the difference between the final position of the crown, the gingival final position of the crown, from this wax-up compared to the final restorations is a difference of 3 millimeters. 3 millimeters is a lot. So if you are trying this in and you show this to the patient, you're showing something that is not really the reality in the end. And there's many more problems, and we will go through the case. I will go through the case with you, because it's very easy to show on social media cases that are additive, just teeth even that I wouldn't prep. I think there's too much disease-free dentistry, disease-free cosmetic dentistry. If you are in subtractive cases like this, there's no way you can show the mock-up in a nice way without removing the old restorations. Florin was just, when we were in the room placing the slides together, he was telling me patients accept much easier from you probably in your office. Of course, after 35 years, they accept much easier. But still, I need to discuss with them. I need to discuss with them. There's a lot of communication involved. What did I learn from this slide? And I learned it from Stefan Kubi, who was doing this very nice lecture just before us. If you have tetracycline and you prep deeper, probably you have a problem, because the color will become darker and darker the deeper you prep. The deeper you prep and the more space your technician or yourself you need, the less you're bonding in enamel, and we all know that bonding in enamel is quite important. But let's go to the mock-up now. So this is the mock-up, it's on top of the tissue. Why do I need it on top of the tissue? Because this mock-up will guide me for the surgery. And the surgery will guide me ultimately for the final preps. So the bone and the soft tissue will be related to the final prep. We can plan all of these things ahead. So on one side, on this side, let me try again. On this side, no, I'm not going to use it. Too old, my hand is shaking probably. Anyway, on the left side of the patient, we're going to crown lengthen. We can measure, you can do anything you want, but you need to understand some basic principles. I think any general dentist should be able to do a crown lengthening procedure. A simple crown lengthening procedure, altering tooth forms by changing the gingival level. And Florin does it differently. He will show you. I'm old school, so I like to change the soft tissue level. I like to open the gum, and I like to see the bone. That's basically what we do. So that's what we're going to do with the patient. Remove the provisionals, and we're going to start to crown lengthen. What is the first thing that I need to try to establish? First thing, as you know, is in incisal edge position. Then you go to the gingival. In the gingival design, it's the zenith position, like you see there. So this mock-up is going to be used to determine the zenith position. You're going to remove the tissue, either with a blade. This is an old case. I can see it's old because I was using the electrosurgical tool, which today I don't use anymore, because you don't know until where you burn the cells. Today I use the scalpel. Much, much easier. Florin and his father are using the piezo to do it. So there's different options. There's not only one option to treat the patient. So we are designing the soft tissue, we are prepping the tooth, we are opening the gum, we are restoring the biologic space. I know many companies want to sell you a lot of instruments, and mostly they are very expensive. You don't need, I have 5 or 6 instruments, and basically if I want to remove bone, like on the right upper side of the screen, it's just the same burr as you use to remove decay. Very simple burr. The only thing I want to do is, I know where is my prep. The prep is related to the mock-up. From the prep to the bone, I want to respect the biology. If I want to respect the biology, I need a distance of 3 to 3.5 millimeter of biologic space. So that's what you're going to do. You're going to restore the bone, and this anybody can do. I think it's much more difficult to extract sometimes a second molar in the lowers, in the mandible, than to do this. The only thing you need to understand is you can only do the surgeries if there's periodontally healthy tissue. Don't do this if the patient has periodontal problems. The second thing is, if you resect tissue, You want to be able to keep a zone of 2 to 3 millimeters of functional attached tissue. Functional means periosteum attached to the bone. And I made a mistake, and it's nice to show the mistakes. So we are restoring the biology, we are re-cementing the bridge. Now have a look how much difference between the original mock-up on top of the tissue and the prep now. It's like 3 millimeters. So what is the normal reaction of all of us? I'm not going to get my patient go home like this, so I'm going to start to prep and reduce the volume on the gingival. What am I basically doing? I'm altering the tooth proportions, I'm altering the tooth forms. And that's something maybe you will explain later on. That's something unbelievable with digital for me. Florin and his team, they can reposition the tooth 3D. They can keep the same form, position it differently, but they don't reshape it as I do. Because if I reshape it, it's going to look completely different. That's what I'm doing, and that's what most of us do. But suddenly your incisal is out and your gingival goes in. So the form, the gingival support, everything changes. So keep this in mind because I think it's important, and that's one of the huge advantages for me of the digital. I can even plan the crown lengthening from a CBCT and make a shell or a provisional before I start a surgery today. So a lot of things are changing. Look at the difference now between the original position from the first wax up and my prep. It's like how many? 2-3 millimeters. It's a lot. Are you going to talk about this bolt-on index calculation you made?
Yes.
You want to show it here or you want to show it later on?
No, later on.
Okay, you're the boss. So I made a mistake, and you can already see the mistake on the canine. So the nice thing about analog and the things that we are doing 35 years is that we have to be creative and solve issues. You learn basically how you solve issues and how you correct your mistakes. So already on the canine now I can see I have a problem. So now, okay, patient heals. In general, for any of these plastic periodontal procedures, we will wait from 8 to 12 weeks, not more. Why not more? There's many studies from Italian groups telling us that we need to provisionalize them for 1 year. I don't need to because it's periodontally healthy tissue. I'm not working in diseased tissue. It's only a cosmetic buccal recontouring of the soft tissue and the bone. So, take an impression, and I think it's important to take, at that time it was important, not to take an alginate but a silicone, to be very precise. Again, the same guy, Murillo Calgaro, comes in. We're getting closer to finalize the case, so it puts more energy in the forms now. So reshapes the forms. What does he reshape? Of course, the bulk on the gingival aspects. You remember, I changed the profile. The incisal is still in the same position. Now he sees again something weird, no? On the model. He starts to reshape. Basically, it means he's an unbelievable technician. Look in the middle of the screen. It's too bulky because I adapted everything. So he goes back, makes a new wax-up. We try in the wax-up. The wax-up is completely different from what I had at the start of the treatment. So it's always a surprise because when this goes intraorally, this is what I see. It looks okay, but it's not okay because we take a picture. What I learned from the Brazilian guys like Murillo and Christian Coachman, all the people that worked in my office 10 years ago already, is taking pictures and analyzing it. And not only taking the frontal picture, but the 12 o'clock, the lateral, many, many things. So now Murillo tells me, listen, this is the design that I would like to have. In the end, for my final crowns. My technician telling me now that I have a problem, I have a recession. I started with the crown lengthening and I have a recession. He wants to change a little bit the incisal edge position, just little details. What does it mean? I am, even if I know since 35 years how to do crown lengthening procedures, and in the beginning I can tell you, 32 years ago we did the first ones. We didn't establish incisal edge position first. It's just visual and intuition, and everybody in the room will need some intuition and some knowledge, but there's certain parameters. What I see with the digital is I can eliminate mistakes in a much, much more predictable way. So let's see how we continued now. Because I've made the final preps. We're going to use lithium disilicate crowns, which is Emax crowns on this case. I'll have to communicate the color of the prep. I'll have to communicate the color of the lowers. This is something everybody should do. But look at the canine now. How can I solve this? You're not going to tell your patient that you're going to graft again. So what is the only solution now? It's changing profiles. What does it mean, change profile? You can reduce the pressure on the buccal tissue just by changing the thickness of the tooth. Why do you need to understand this concept? Because with implants it's the same thing. You all get these implant cases back, a single central, you try in the abutment, tissue goes up 1.5 millimeter. You reshape the abutment, tissue goes down. Tissue levels, vertical tissue levels, vertical soft tissue levels, we can change them non-surgically about 1.5 millimeter without just doing any surgery, just changing the profile. So let's see what we did. I take an impression, I make a new prep away from the first prep. You see, the second prep is away from the highest prep. You try in the basic bake, and this is not new, this is something we did 20 years ago. And I think we should understand everything what we do around natural teeth before we go to implants, for sure. So you have the second prep, the technician prepares the crown, the bisque bake, the second bisque bake. You try in the bisque bake, you take the burr and flatten quite aggressively the top part up to the bone in the sulcus. So what happens? This happens. But you see, why did I need to do it? Because the planning is only planning. We can try to do the best in the analog way, but we are limited. So making the final restorations, at that time trying in, what did I try there in the left upper screen? I tell my technician, listen, now your last wax-up was a nice wax-up. It fits in the face of the patient, I like the forms, the patient likes the forms. So what did we do 10, 15 years ago? We took another impression of the provisionals, we send him, just copy please, it's okay, copy. Never ever, the best technician, the very, very high level technician will get you this crown back like you ask him to send it back. It's like if they need to put a signature. Can be better, can be not better, can be disappointed, can be fantastic. But you don't know in advance. So look now, the try-in on the right side is much longer, it's like 1 millimeter longer than the provisional again. So it's changing all the time. How does it evolve? And I think we should someday organize lectures with long-term things, because nobody is, I heard Stefan Kubi, who is a very good friend, and I really like his material, really like his material. He told me that and he told you this morning also, I heard it, it doesn't make sense to show cases after 2, 3, 4, 8 weeks. Because we all have maintenance. You know what is maintenance? It means I made a mistake on the canine. The tissue came down after 2 years, or was down already after 6 months just by reshaping the profile. But if you look at the same case some years after, you will see that after 7 years you have this. And this is maintenance. And we need to understand how we maintain a case. So what is your solution now? So it looks nice. 10 years ago, the problem of value of lithium disilicate was an issue. But the technician manages today to make very nice looking full arch cases with lithium disilicate with Emax. We are using different materials. Basically, if I categorize, the best material still now is for me feldspathic porcelain. But it's limited, the application is limited. The next one is the ones we are doing now with Timisoara, which is Empress Scat.
Yes.
No, multi-layer. Very close. Zirconia can be okay. When is zirconia okay? Dark substrate. What about lithium disilicate? Lithium disilicate for full arch we use. Posterior we use full monolithic, just stained. Anterior, this was layered, and at that time they layered also on the palatal. Palatal layering is only for the ego. Today we just, even the incisal edge will be monolithic, only eventually buccal layering if it's a difficult case, otherwise it's staining. We know that we don't have chipping anymore, there's no issues. So 7 years, how did we restore? And this is something you need to understand, because this is going to happen in my office and in your office. What was the mistake? We cut away tissue too close to the mucogingival junction. We try to restore just by changing the profile. Tissue comes down, but it's very thin, the tissue. So now we remove the decay. Remove the decay. You measure the depth of the decay. If the depth of the decay after removing it is 1.5 millimeter, your connective tissue graft should be 1.5 millimeter. You're just restoring what was there before. So I'm reshaping again a little bit up to the bone. We take the connective tissue graft from the palate, from the tuberosity, and we're going to restore the case like this. This is maintenance, pure maintenance. And we have cases that we see after 30 years, 20 years, 10 years. This is going to happen to all of us for sure. How does it look 10 years post-op? This is how it looks 10 years post-op. So it still looks nice. Why does it look nice? Good technician, maybe good materials, occlusion is okay, but it's like a process, and more like a procession. You go 2 steps forward and 1 step backward, 2 steps forward. And in the end, after working with Florin, since 2-3 years now, no, longer, but on the digital aspect, I understand now that most of these problems, I would be able to solve them if I go digital, because I will be more predictable, much more predictable. Predictable in design especially. Any comments, Florin Cofar?
They are exactly the ones you told, and exactly the slide on the screen. Basically, analog is a long game of adjustments, which works perfect, as you just saw. There are the most beautiful cases in the world, and the ones that have the most recalls are still analog. But like Eric said, it's always a game back and forth of adjustments. So in digital, remember I made that introduction, which was pretty sad for, you know, the whole concept of digital. Now I will try to change that by changing the way we think of using this technology. And the way that we need to change our thinking is again on this slide. In analog, we design, and that's fine. And then it's a game of designing, adapting, going back and forth. And in digital, what we do is we copy. Why? Because what do we all want? We want a natural, nice-looking result. And the world is full of basically good, natural examples. And I will tell you a very short story when my mindset was changed, because sometimes you have some people that tell you one sentence and that sentence stays in your head, and then it takes, you know, maybe weeks, months to understand, but when you understand it, your whole thinking is changed. And I remember I met Paolo Cano, who probably some of you know, is, I think, as a dentist, he's probably the best that I know, as a clinician. He's amazing, not only dentist, but technician. He's a genius. He's not human, almost, in terms of what he does. And for the ones who don't know him, he has a book, Challenging Nature. So basically, he did all his life teach a lot of people in how to create morphology. And I think for one of the reasons why Brazil is like this today, that you go to a big meeting and half are Brazilians and half are from anywhere around the world, is also credit to him in many ways. Because all of the names you mentioned and many others have at one point been at the Paolo Cano course to learn wax up. Now, when I met him, I remember that I saw him working on digital, and it was a Sirona system a couple of while back, which is much more limited than the ones we have today. And I remember I asked him, why do you even want to go digital if you can do some things which probably nobody else can? And I remember he told me one thing, Florin, if you look at the central, you see a line angle. And with your eyes and with your hands, you try to copy that, but that line angle, mathematically speaking, is probably 1,000 or 10,000 points. And if you understand this simple concept, you understand you can never truly copy. And this man, in his humbleness, told me, I tried to copy nature all of my life, and after 30 years I realized I cannot. And then what you realize is that this is actually the power of technology, the power to compute and to actually turn this, first of all, get this STL via a scan, and then turn the scan into a physical object by turning it into the path of a bird. And I will play a short video just to explain the concept in which we are thinking right now. And then I will go into details to show you the version of what Eric showed in the digital today with the pros and cons. And I will try to spice it up with busting some myths, you know, that are floating around, and also talking about what I think is important.
I remember in the early days of school, I was an Olympic student at math. That lasted one semester. The following semester, I was flunking the class. This didn't happen because I suddenly didn't understand math anymore, but I failed to understand the application of it. It was just a mind game with no real meaning, and at that age, you can find much more interesting games. So I stayed away from it, and I became a dentist. And ever since, I pursued aesthetics and understanding beauty. 15 years later, I learned one very important lesson. At the core of aesthetics is shape. Shape is geometry, and geometry is mathematics. In a digital world, this was a huge game changer for my mind. Nature is an unlimited library of designs, a library of natural beauty. It is DNA in mathematical form. Every tooth, every shape, every texture nature ever created is uniquely beautiful. And today, we can copy it. Don't get me wrong, nature will always be one step ahead. Like every ideal, you will never reach it, but you will find fulfillment and greatness on this journey. It will always be like chasing the stars in the night sky. We will never reach them, but they helped us navigate the seas since the dawn of man.
So basically, how are things today? Like Eric said in the beginning, and like we concluded, remember, we are no longer looking at the patient so much in real time. Of course, you evaluate him when you meet the patient, but after that you look at the data. Because getting this data is what we call the digital clone. It's fast, and it's also advisable that you basically build an environment where this gets done automatically in a clinic. Why? Because all of this skill set you see here is not necessarily for dentists. It's for dentists to use. How many of you learned to take pictures in dental school? How many of you learned to scan in dental school? How many of you took DICOMs in dental school? This is technology. This is something different. And it gives us the input on which we plan. So how we work today, we have like one person who does this, which can do for a 20-man team without any issues. Remember, as a dentist, you're your most expensive employee, so it's smarter to just get it done. But we need this data. Now, once we have this data, what is design today? You can take anything from anywhere and use it to design. Basically, in this case, just to show you, we took shapes from other patients, which are natural teeth. As you can see, for example, we take the lateral from this guy, we take the central from this girl, we take the canine from this girl, which are natural shapes. They are beautiful. I don't need to change anything. I just need to select them, and then you create a custom library that you use to design your case. How do you create a library? Well, very simple. You have a scan, and when you have a scan, basically you have to break it down into smaller STLs, which is the shapes of the teeth. And all you have to do, I mean, there's many ways you can do it, but the simplest one is you use any kind of ortho add-on of a software. The first step in orthodontics is always segmentation. Segmentation will grant you from one STL with a whole arch, like individual STLs of the teeth. And this you can take and use in design. And basically we just took those shapes, positioned them again like Eric did the first design on top of tissue, on top of everything. And this is the diagnostic design or the motivational design, which I believe it's the most important concept for me in digital dentistry. And this, for many years, I've been debating with Eric because he was telling me you have to put it in the correct position. And I agree, you have to put it in the correct position eventually. But before you put it in the correct position, you need to cut or you need to reduce. And that's what I was telling him. Eric, you tell a patient, jump like this, they jump like this. This doesn't happen to the rest of the world. The rest of the world, we need consent. So the patient needs to basically agree that we cut or reduce, and he has to tell us, okay, I want to do the treatment, I'm willing to pay, I'm willing to do this and that, and this is how it looks. Now the problem was, again, like Eric was saying, that there's a discrepancy between, you know, one first mock-up, second mock-up, third mock-up, and so on. But this is different in digital. Why? Because you're working with the same library. You're basically playing with position. So the first design is on top, and what you're going to do, you're going to use this edited design to basically skip the whole wax-up. There's no need for a wax-up. I will tell you, comparing analog to digital, areas in where I believe analog is still king, and areas in which I believe digital is better. And for design, for this part, we haven't done a wax-up for 2 years. I've only do it when we have some, you know, friends coming over, technicians that, you know, out of comfort for them, we let them do it in their own way. But if we are doing the case, we only do this because at the end of the day, that's what you want, the natural shape, and this is the easiest, fastest way to do. So this is what you're going to show to the patient. Let me go back. And basically, this is going to get you consent. In this part, the patient will say, okay, I want to do the treatment, and I agree, I understand that I need to do this and this and this. And basically, what we tell patients is, this is the treatment plan. And to get from here to here, you need to do crown lengthening, you need to do certain things, and we compile everything visually. Now, everything in dentistry revolves around design, basically. And when I say design, I do not mean aesthetics. Design is more or less, imagine that anything we do in dentistry, we decide like on an XYZ equation, horizontal, vertical, sagittal, where we position a new structure or reshape or move an existing structure. So once you have design, ideally, you can guide all the other procedures. And this diagnostic design, even though the sagittal is off, the horizontal and vertical, they are correct. So this is the guide we use for crown lengthening. Now, very important here, whenever you're designing on top of tissue, you have to understand one simple concept. You always have to use shapes which are more tapered than existing ones. Why? Because the maxillary is centripede. As you go up, it shrinks the space. And if you're going to use, let's say, shapes which are wider, what will happen is you'll make your surgeon reduce unnecessary tissue from the papillas, which is not what you want. Now, for the crown lengthening, the alternative of what we do, of what Eric showed you, we do a lot of this flapless procedure, which is basically a, again, a patent from a Brazilian company, uses a hard diamond that you can go in the sulcus and reduce the bone without cutting from the tooth or scratching the tissue. Now, what is very important here? Remember in that digital clone I showed you that we do basically DICOMs for almost all cases. Why? Because again, when we were debating whether you should do a crown lengthening with a flap or without a flap, we realized one thing, I mean, we agreed on one thing. It all goes down to one specific aspect. How thick is the bone, the buccal bone? Because if you have thick buccal bone, you have to open a flap so you can see the bone, so you can bevel. But if you have thin bone, then most of the time you don't need to do the flap, and you don't need to, I mean, you can do this flapless procedure that you have less trauma, and you can also, in cases like this, you can do the crown lengthening and the restorative at the same time, which is a huge advantage. I mean, you lose those, that healing time is completely mitigated. And we realized that both options are real, because when each year I would go to Antwerp a couple of times and Eric would come to Timișoara, and in one side you have patients from Belgium, in the other side is patients from Romania. Now, in Belgium, most patients have a lot of bone, which for crown lengthening is more difficult. And in Romania, probably you all know, we do not have a lot of bone in our patients. I mean, the buccal bone is usually very thin. So if you have a DICOM, you can evaluate whether or not you can do this kind of procedure, and basically if the bone is thinner than, let's say, 1.5 millimeters, you can do this kind of flapless procedure. And then just make sure that, again, you clear this 3 millimeters of biologic width. Now, the next thing we do when we do a procedure like this flaplessly, we can go directly to the restorative part. We use some cords which basically have either aluminum sulfate and astringent or epinephrine and astringent. They are different than the one that most of you are used with, which is Ultradent, because it's more difficult to work with in the beginning. It's more stiff. And also because of, especially if you use the epinephrine one, you have to work with anesthesia, because it causes like a pain to the patient. But why we use them? Because the retraction is superior, a lot superior. I mean, with Ultradent, maybe in a full arch you have like 1 minute when you remove the second cord to take a nice scan or a nice impression. Here you have probably 15 or more. So I can do a lot of things in 15 minutes. I can even have a coffee during this, and it's very, very nice. Now, prep guides. Here, a very important thing. whenever we do cases like this that have, you know, have the reductive steps, so you have a reductive case, and then obviously your first design is more buccal. You can never use the prep guide from the diagnostic design. You can never use the buccal guide. You can use the palatal guide where you can see the length. And then if you want to go precise, at this step maybe it's better you rescan and simply reposition those shapes to get the new design and you make a prep guide. This is one way. A more practical way, which we most of the time do, is I simply reduce the length and create the space using the palatal guide, which is the same. And then what I do is I simply go and flatten my emergence profiles of the teeth in a way that's acceptable, having in mind the minimal thickness which I need. In the past, I would use 50,000 instruments for prepping and rubbers and a lot of things. Nowadays, like Eric's saying, I also simplified a lot. Basically, I use 1 or 2 chamfer burrs. It's very important in digital that you have a small chamfer for a simple reason. You never want to polish after bonding or restoration in the mouth. Why? Because on the buccal surface, most of the time you will have stain. If you have to do that, then it's an issue. But if you have a very thin chamfer, thin can be 0.2, it's okay, as long as it's clear. And then basically what the technician will do will simply take the same library, which is in position, go to the prep scan, just switch the scans, the initial with the prep scan, and simply change the sagittal a little bit, bring it to the back a little bit. So we have from this kind of situation, which is on top of tissue, to this kind of situation here. And basically, then we can generate the final restorations. And now when it comes to details, most of the time, what you see here is some nice milled provisionals, which are great. They are PMMA and they are sandblasted and spot etched, because otherwise you cannot bond, it's going to pop off. However, this we do only in some situations, like if it's if we need healing or if we need any kind of test drive, but not for everyday use. For everyday use, it takes too much time to do. Why? Because before you mill, the milling time is not long. But basically you have to design the whole case before you mill, and then if you mill PMMA or ceramic, it's the same time. So if you want to do something like this, it's going to take you, I don't know, the patient has to walk around for maybe 2 hours, realistically. So you don't do this every day. But it's nice to show that obviously you can never get this kind of healing with Bisacryl. Then the same project, you can mill in ceramics. Now, like Eric was saying, I agree with him completely. The best material for me is feldspathic. Let's say, the homologue of feldspathic in digital is glass ceramic. Specifically, this material, which is Empress CAD Multi, is a multi-layer block. The most important thing when you work monolithic, because in monolithic you have a huge advantage, you have shape, but you have a disadvantage, color in terms of depth. So then you need a multi-layer block that basically will help you get over that effect. But if you are to choose, what is the most important thing in aesthetics? Shape. What is the second most important thing in aesthetics? Shape again. After that is color and everything else. So this is why, again, people run away from monolithic because of color. But remember, first of all, color is secondary. Second of all, with material selection, sometimes it's easier to manage. Now, models. Everybody is going crazy over printing or milling models. And this is a nice example of a model where we milled the dies, and we milled them from like Telio, which is PMMA, and the base is from the surgical guide material. And it works. I mean, it's very precise, it's very nice. You see it's beautiful pictures. But it's not real. I will tell you why. That base, in order to print it for 25 microns, took 7 hours. on an average desktop printer. The dies took 4 hours. Now, who is crazy enough on a day-by-day routine to spend that amount of time and block the technology that you use for, you know, designs or milling ceramics to do models? Do you understand? I mean, practically, it fails, this step right now. Compare this to just taking an impression after you scan and doing a cast model. This is the issue. And there's a big problem in education when people will present you protocols that are in reality proof of concept, which is here I'm showing you that is possible to do, but I'm telling you that is not practical to do. It's not practical because you have to lock down your technology, which we all have limited resources, to do models instead of doing ceramics or any other stuff. So the thing is, I believe that this will change when we will have a dedicated solution for models, meaning that at some point we should have like a special low-cost, high-speed machine that would do models. Until then, I don't really see it feasible to use a Roland or a Wieland or any other machine or even a Formlabs printer to do this, instead of just having the classic cast model. Here you can see, again, the restorations on the model. These are all monolithic, so everything I'm showing you right now is restorations that you just mill, stain, and glaze, and that you preserve the shape from the library. Like, you would be surprised, but you know what the biggest problem is from not getting this shape as you see it in the library in your final restoration? The most common factor for that not happening is not the software, is the operator changing the shape. How do you fix that? Simple, don't do it. But it's very difficult to unlearn people for, you know, from things that they've done for many years. But it's not necessary. Less is more here. This is a Trine. Again, what you see is Empress CAD Multi, monolithic, that simply has a bit of staining. And actually staining, when you have good substrate, is not really necessary. It's just, you know, the cherry on top if you want to compete with, you know, it's for our, basically our own pleasure, let's say. But I don't think that the patient will make a difference in this kind of case. It will matter if you do it in cases with dark substrates and stuff like that. So outside of this design, the dentistry and the rest doesn't change much. I mean, we bond the same, we isolate the same, we prep the same. What is changing is the mindset and how we handle design. And this is immediately after bonding. And here you can see also we just changed some elements in the lower to adapt occlusion. And this is the final result. Now, I'd like to handpick some conclusions on this comparison that we're making right now. And one of the strong points, if I am to pick, again, why I do digital dentistry, because I told you in the beginning, it's not the cliche arguments you hear every day. It's other things, and some of them I will tell you right now. First of all, the ability to do a diagnostic design easy, which is the center of a treatment. And let me explain again what diagnostic design is so everybody understands it very clear. And I will respond by addressing an issue which you're all thinking about right now. What you do in cases where you have teeth sticking out like this. What do you do then? Or how do you do a diagnostic design then? Well, in order to understand how you can do it, it's a simple mathematical principle. Remember that design is simply a relationship of position between, you know, the STL, which is the model of the patient, and STLs from the library, which is the teeth you want to use. So you can position it everywhere, and basically design is just selecting something and putting it somewhere. Now, this is an arch, what you can see here. And I put it in a circle because basically any arch, you can put it in like half a circle, right? So then the formula of the perimeter of a circle mathematically is like 2pr. We learned this in school. Half a circle is pr, so 3 times 14, 14 times the radius. Which means, if you look here, what happens, the more you go buccal, the more the teeth will scale, obviously, because you increase the area of the circle. But we cannot calculate that. And I can tell you that, for example, if you go 2 millimeters more buccal, or like Eric went 3 in that analog case, do you know how much a tooth shape will scale? 6%, the central, average R shape. What does that mean? Literally not relevant, especially because you're not only scaling that central, but you're scaling everything. You're putting the shapes here, so the patient can see, so you have a position where you don't have to cut anything. Patient says, okay, and then you go again with the same shapes to the back. And that's it. So, to give you an example, in this kind of case, many times the initial design looks like this. So you are on top of everything you can see here is more than 2 millimeters, probably 3 or 4. But then how do you fix that in the mouth? You would simply position it where it is, and then there's 2 tricks. One, a black marker. We're going to paint what is under, because it's going to blend with the dark inside the mouth. So if you want to reduce something, you cannot cut it before the patient says okay. So you paint it with a black marker, and then you have some pink composite, because when you go too much outside of the arch, when you're no longer in relation to the tissue, you can simulate the illusion that the tissue is in relation to your design. Only because after this you will again go to the back. And basically you're going to get 2 videos like this, and another trick is the second video, you're just going to scale it down by probably 10%. And what happens is, people will look obviously at the teeth. They never notice that the second head is slightly smaller, and then it looks the illusion of the final. And then of course, this is translated in this particular case to an ortho treatment. Because one of the most important concepts you have to understand, that basically the wax up, or the design as we know it in analog, is the blueprint for restoration, for ceramics mainly, right? Now the diagnostic or the motivational design is the blueprint for a treatment plan, which is you visually want to illustrate what you will do as a treatment. That can mean that you do a design only for ortho, only for crown lengthening, or for a mixed treatment. It doesn't matter, and this is the end result. This is a beautiful case with the surgery done here with Puyu and surgical ortho. But everything, imagine this kind of case. You know very well, for example, particularly here, case acceptance when you tell people orthodontic. They all run away. This is first thing, acceptance. Without acceptance, you're not going to do anything. Second is obviously guidance. And here you can see like a comparison. So the second thing is predictability. If you look here, you see the initial, you see the shapes on bisacryl on top of tissue, and here you see the ceramics, which are again in their final position. So the sagittal of the 2 is different, but since the shapes are the same, it looks the same. So we can preserve the design in different steps of the process. This is already a superpower, because like we were saying, in analog you have a game of adjustments, and always you have differences, and you're taking from here, adding there, and here you're only playing with the library and with the position, which is completely different. In simple cases like this one, because a simple case that only has restorative and crown lengthening, or in complex cases like this, which is a surgical orthodontic case, is the same. You are basically treating first a clone of a patient digitally, and then you're reproducing it predictable via different manufacturing processes. You can turn this into tooth movement, into a bisacryl design, into a ceramic restoration, and so on and so forth. Last but not least, or not last, but another argument here is morphology. Another thing which I love about digital, by having libraries, first of all, I can have any library I want. I like a tooth, I like a shape, I can just grab it. It's there for the taking. And then you can have from the same technician different shapes, which doesn't happen in analog. Why? Because every one of them have a certain style, which they tend to reproduce. So here, for example, if you notice, the centros, the same centros were used in this case and in this case. And you can see the predictability of using shape. Everything else is different. Nowadays, when I do a case, I specifically ask, I mean, the technicians I work with already know that I don't like to repeat libraries. I mean, if the whole case takes 1 day and a half to do, it's 20 minutes to make a unique library. It's worth it. I mean, uniqueness was not in our toolkit until now. Now, it's really there. And the last thing is guidance. And this we will talk more about implants. And Eric again will go and explain the analog. And then we'll go into digital to understand what we can do about implants. Eric?
Okay. So I think there's 1 or 2 remarks, Florin. I think the cases like you did, especially when you have thin bone, it's, the best option is always not to raise a flap because you're going to cut the blood supply. But even if you would see, let's say, our way of treating cases change a little bit, because today we are grafting and crown lengthening, placing the final restorations. And if you need to raise a flap to alter the bone level, I think the healing of the tissue will always be better with the final crowning position. And it's normal. Tissue will heal much better against porcelain than against resin, for example. So there's a lot of things shifting. So Florin asked me now to, before he shows you digital way. And the things come back now. I mean, it's going to be designing, it's going to be implant, because this lady came back from orthodontists, and not really very good orthodontists. We have a problem on the left central, we have an endodontic problem. It's maybe not the issue now, but you can see there's an endodontic problem. So I send her to the endodontist, goes in with a microscope, he tells me there's a crack in the root, so we need to extract. Okay? So since many, many years we were thinking, what is the best way to try to extract the tooth and to copy nature? 2, 3 years ago we published an article on this in QDT, because basically when you think what nature gave, if you compare Florin's cases to this case, the best shapes are the natural shapes that there is in nature, in natural dentition. The best shape for a component from your implant to the crown is nature, which is a copy of the root. So not only we need to copy teeth, we need to copy roots, and there's a certain protocol. And if we want to explain digital companies, or if I want to explain Florin, for example, I need to do it in an analog way. So I'm going to show you the analog way, Florin is going to go the digital way. But the same issue, first of all, I need to establish lines. We're going to make a provisional, make a wax up. Wax up is very important. I think the technicians that I've been working with, and this is again older case today, like Florin said, you can do it digitally. You don't need to do it this way. But this is what we did some time ago. So if you look at it, they're changing tooth forms, they're reshaping everything. So you're building basically the design, or building the maquette of the case. From this point on, if I will place this intraorally, I will be able to decide if it's okay and if it's not okay. If it's okay, I'm going to determine the treatment steps and all the specialties involved. I'm doing both pros and perio and implants. So it's maybe a little bit easier to communicate with myself than to communicate with somebody external. But again, we try to get some simple principles in and simple initial design with the wax up. designing everything, and trying to go intraorally. I know I need to extract a tooth. Now there's two reasons why I want to make a provisional. First of all, because I want to see if the midline is correct, if the forms are correct. The second thing is, if I extract the tooth, I need a provisional restoration. Imagine now I will have the ideal provisional crown, and with the ideal three-dimensional gingival position. Where does it come from? From my prep now. It's a 2-minute prep. It relates my future crown margin to the existing soft tissue. From this point on, from my prep up to my implant, which will be 3.5 to 4 millimeters below the tissue, I have to copy the root. So you have the crown with the ideal three-dimensional position supporting the tissue. You have the intermediate zone supporting the soft tissue, and you have the implant supporting the whole restoration. So we're going to start to prep. We change the midline. You prep according to the midline, and you make a provisional. Now let me go a little bit on, because this is the healing after 8 weeks, and we're going to go for extraction now. Before we extract, we're going to guide. Florin showed you a picture of a guide. Not only guide pros, but guide implant placement. I did thousands of implants that I placed in extraction sockets without a guide, but I can tell you, just by using a surgical guide and allowing you to focus on the details of the soft tissue and the pros, and just drilling through the guide and making sure that your implant is positioned in the correct way, makes you feel more comfortable. So today we are really planning all of these cases digitally. It's important to relate the implant position to the future crown position. If you use the old position of the tooth, maybe it might not be related to the future ideal position of your final crown. So you have these, we know the study, that's important. Maybe there's a study from the group from Gonzalez, Oscar Gonzalez from Madrid, telling you that there's always, basically if you make a resume of the study, there's always more bone in reality than on the DICOM files, on the CBCT. If the bone on the buccal aspect is less than 1 millimeter, sometimes you don't see it on the CBCT. That's important to understand. So this is the type of guide that we have. We related to the superimposition of the STL file and the DICOM file. We will go for the implant placement. Something wrong with your... I'm going to go like this. Okay. And the next option now. So first option would be to copy the root, and that's what we've been doing since many years. Second option is you take the DICOM file of the root. You can see it on the left side. From the DICOM file, you will clean the root form. You will superimpose it on the model on the screen, and you will fabricate either a provisional crown, either an abutment that is related to the tooth that you're going to extract. Why do you want to relate it to the tooth that you're going to extract? Because that's what nature gave to the patient to support the tissue in the right way. That's a simple concept, a very, very simple concept. So many things you can do. We even milled some years ago, 2-3 years ago, we printed and we milled from a DICOM file a tooth, multi-layer tooth. So it's very close to the extracted one. So I can use it for the provisional. So there's so many options today, and it's up to you to choose the option that is working best in your hands. Anyway, just to explain you the principle, because you need to understand it before we go to Florin. We want to copy nature. So I took an impression, a silicone impression. I extract the tooth. I place the tooth back into the impression. I pour a soft tissue model, and my tooth is in the model now. So basically, from this point on, I have the ideal contour. I don't need to do anything anymore.
It's like a surgical Geller model.
Yes, that's a good... Yeah, that's exactly what it is. So what we did is we went the other way around. We asked the company from the DICOM file now to make this kind of abutment, to check after the surgery and when making the final restoration if this would fit the alveolar. And it fits exactly there. So let's see what we did now. We take the guide, we place the implant. We know from many articles that guided surgery really has advantages. We place the implant, and what do you see now? There is no guide, because it's an older case. And since I was used to work freehand, I used the guide only for the drills, but I placed my implant freehand to control the vertical, which is stupid. And I like to show you the mistakes I make. What happens if you place your implant free without a guide? You want to place it palatally because you want to leave a space to develop the contour. If you place it palatally, the more you go up, the more you will hit the palatal bone, which is the hardest part of the alveolus. So you will shift 2, 3, 4 degrees. You will shift to the buccal. Shifting 3, 4 degrees means transforming a screw-retained crown into a cemented crown. What do we try to do today? Screw-retain. Screw-retain for many reasons. It's so versatile, the system. You can screw and screw whenever you want. What is the biggest cause of peri-implantitis besides the surface of the implant? It's cement. Cement where you don't want to have the cement. Using a connective tissue graft, picking up now. So you do a pick-up impression during the surgery, okay? And you place this pick-up on the model. So now I have the ideal position of the implant, which is basically 3.5 millimeter below the buccal soft tissue level. From this space, I will have one component, preferably yellow anodized, 2 millimeters away from the implant, and have this component 1.5 millimeter copying the root. And this form that you see now, if I would ask you to make the ideal profile, you would never make this design. It's impossible. Which means that for years we have been working on profiles without understanding why, until we understood that it's better to copy the root. Now imagine, as Florin said, that if we would have like a library not only of crowns but also of roots, it would really help us a lot. So the implant placement with the components, the healing, and then I think it's important to understand a few things. If you want to work on soft tissue, what is the worst thing you can get? It's the red line. If you place too much pressure, if you don't anticipate by adding some graft eventually, you will end up having the red line. That's the worst kind of situation. Green is the easiest because you just need to push it up. How do we work if we want to change the profile? First, we will treat the vertical component and only then the horizontal. So don't try to do both at the same time. And you can see it here very clearly on this image. Let's go now for the final restorations. And I think if you understand this, you will understand very easily that it's a lot of work to do this. It's a lot of work to go back and forth to the lab for a single crown. It takes you half a day. So imagine now we find a digital way of designing this very easy, 5 minutes. Fantastic, no? It's just the evolution of things. What we were doing 4 or 5 years ago already in an analog way, we translated it to digital in Florin's office in Timișoara. Now, the preps, and I had Victor Clavijo in the office at that point, is probably one of the best I know in prepping. Since we need to change the midline, you will need a vertical insertion axis on the central. You have a horizontal insertion axis for your veneers on the 2 laterals. But let's focus on this one, because now this is my result. And you need to understand that when you remove your crown, the tissue collapses. And even if you place some flow and take the curing light, it's not the real thing. So we will always work from the day one on the first model that we had with the ideal contour. We are using triangular implants since 2012 now because it allows you much better blood supply, much more soft tissue volume. This is something that we did develop with Nitzan Bichacho and Yuval Jacobi with MIS company in 2012. But what is the main thing about this picture? Well, and I see the same in Florin's clinical case. We, as a dentist, we learn things like maybe 10 years ago, maybe 20 years ago, you copy something from a lecture. What was the thing we were used to do with implants, especially in the aesthetic zone. And it doesn't matter if it's an extraction or not an extraction, it's adding connective tissue. What happens now prosthetically? There's too much volume. Why is there too much volume? Because we copy the root. I don't need extra volume where I copy the root because the soft tissue is kept out by the prosthetic component. So we need to change our way of thinking. Probably you don't need it. And if you would add some, try to add it in the 2 millimeters where you have the concave component, but not in the last 1.5 millimeter. Because this is fooling the eye of the technician now. So let's go on now. Final impression, making the final restorations. We try to copy nature, so which means if, and that's just how we do it, there's many other ways to do it. If we are working on the natural central and on the two laterals with a very nice color substrate, and if I have an implant in between, I want to copy nature, which means I want to copy the natural tooth in the abutment. And there's a few principles. First of all, there's colors, there's shape, there's line angle position, but mainly 99% of the transmucosal space should be abutment. There is no use, there's really no use to cement this kind of veneer on top of this abutment subgingivally. It doesn't make sense. It's a copy of the root, so don't change your biological principles if you're working on implant or on natural tooth. So making the final restorations, Geller model, respecting biology. That's something we need to do all the time. Making the finals, cementing. So we are going to try in the abutment now, intraorally. If everything is okay, in the lab they will cement the veneer in the lab. So you cement the veneer in the lab. We don't like to cement these veneers on implant restorations intraorally. So we have 4 veneers, and this is what you see. Now, look again at the buccal volume. What is this buccal volume doing? It's prohibiting the light to go where it should go, and it's creating like some kind of a shadow because there's no light entering in the gingival zone of your implant restoration. And you will see that these connective tissue grafts, and there's a study from the group of Gianno Ricci also telling this, that if you take from the tuberosity, 70% of these grafts have the tendency to grow. If they grow, you have to reshape it. And that's part of the maintenance, and nobody's talking about this maintenance. If there's too much volume, just take a burr and remove the volume. It's very simple to do, and I will show you later on. So we are trying in now the abutment, and the abutment is a copy of the tooth, exactly a copy of the tooth. And I think we have like a little video to show you. And video is very nice because you cannot Photoshop it. It's the reality. So we try in the abutment without anesthesia. We just place this abutment and we wait for 20 minutes. If the tissue is in the right position, goes back to the lab now. And if it goes back to the lab, they will cement in the lab the veneer. Meanwhile, we will cement the veneers intraorally. One other thing. Whenever you are working with an implant with a conical connection, there's always problems with the contact points. Always. Because you are transferring with the impression coping to a model. The technician needs to place the replica on the model, on the transfer coping. So there's steps that don't allow. Look at Victor, he's struggling with the contact point. Now, what is the best solution? And again, I told by myself, I cannot forget it, because like Florin said, Paolo Cano, and I know him very well, I only believe what I see, so I invite many young guys in my office, but also like people like Paolo Cano. He's the best, he's like you say, the best of the best dentist in the world. And he told me one day, if you have problems like this with your contact point, what are you doing? What are most of us doing? We take a blue paper, we push in the crown and the adjacent crown, you take it out again, you take a rubber wheel and you just adjust the contact point. But how do you adjust it? It's like a circle most of the time. You adjust the contact point, you create again a circle. If you have a circle, like a round contact point, there is mobility possible between the teeth. And he said, why don't you use a GC strip, these metal strips, you place the two crowns, you pull it on one side and you pull it on the other side. You create a contact surface. If you have a flat surface, the teeth cannot move anymore because they're locked in a certain position. So he told me, go back to your cases from 10, 15 years ago. Sometimes in very periodontally healthy patients, you see recessions and you don't understand why. Check the contact point. If there's rotation possible with a contact point, you can have these recession issues. So let's go to the finals. We bond. We don't make a difference now between an implant or a natural tooth. You just place the rubber dam. I think it's safe to do. So we bond this one in the lab, day of the surgery. And I need to go back one here. Let me go back one because it's important. Look at this now. What is important to understand, and that's what Florin was mentioning, and I'm always trying to refer it to digital now. Your technician, if he works on a model like this, with a black space in between the two teeth, he will have the tendency to close it. The tendency. But you need to argue with him and tell him this space is going to close in time because normally you relate the contact point to the bone, to the interdental bone. What happens if he closes this contact point? He transforms a case with triangular tooth form into square tooth form, which is very bad. Because if you close it, wherever you have tissue, wherever you have porcelain, you cannot have soft tissue. So leave the space open, and that's what you said, and you're completely right. I have the tendency, because I'm used to, if I'm talking to Lenu or to Darius in Florin's office and we are designing a case, many times I'm telling them, listen, can you add a little bit there? Can you remove a little bit there? It's the worst thing to do. Basically, it's the worst thing to do because you're changing nature. So don't change this, just wait. Takes you 6 months. Look at the volume and the height. Changes completely. After 2 years, what can happen? Well, you see there's like a shadow on top of the central. You see the shadow. It's the volume. There's nothing with the prosthetic material, it's just a volume. We reshape the tissue with a burr. Take the diamond burr, you don't need water because if there's water you slip. There's no grip. So reshape it like this, take a smaller burr closer to the tooth, and that's basically it. So if you reduce the volume, the light goes back to where it should be, and the value of the restoration is completely different in the end. So this is maintenance. We should try to show you maintenance of things because it's very, very, very important. What to do if the tissue comes down? Well, if the tissue comes down because of the volume, mostly if you have too much volume, tissue will come down also. So how do you restore? If there's a vertical problem, cut away the tissue first and then you flatten. Not the opposite. First you cut away, then you flatten. This is after 3.5, 4 years. You can see the graft peeping out. Many of these cases, your first initial incision will always migrate apically. Even if you cover the graft completely with the soft tissue incision and with the suturing, there will always be like an apical migration of this outline. So this is what we did, and this is what I brought to Florin. I told him, why don't you just transfer what we did here into digital? And it took us some time, no? It took us almost 2 years before we understood what was happening.
So I will try to illustrate again the same concept in digital and highlight the differences. One of the differences is the following. When you are doing this in analog, at every single step you have to go back and take some kind of record or impression and start from that situation, so you have many steps back and forth to the patient and to the lab. In digital, you are working all of this time on the data. So imagine that if I have the same data, we can create 5 different treatment scenarios, all digitally, get the components, and then you don't need to go back and forth. I mean, you're simply gonna take the guides and do the procedure. And let's start with, you know, the basic. One of the first things you have to do before placing an implant, obviously you need to extract the tooth, right? Well, instead of doing it physically, you can do it digitally. But before I do any kind of extraction, I want again to make sure that I relate to the final design. So what I want is I want first to mirror this central on the other side. And I want to mirror not just the tooth, but also the profile of the tissue. So what we can do is simply we can go around and select the area we want to copy. And this is Darius, one of our technicians, and what he's doing is he's copying this entire area and positioning it where we want it. So basically we simply mirror a tooth. Everything I'm showing you happens basically prior to surgery. It's like, imagine in digital it's like the pilots for fighter jets. You are the pilot as the dentist, but there's the control tower that tells you everything. Go right, go left, this kind of things. And this is the planning. Now the next thing is the extraction. Most of the people that do extraction for guided surgery, they simply do it like this. They select the tooth and simply take it out. But if you simply do that, what will happen is you'll end up with a hole that you will fill automatically. But what do you see here? I completely lost all the reference of the zenith of the future tooth that I want to use. And that's the most important part. So I have no reference. I just have a hole there for the sleeve for the guide, which is okay, but it's not sufficient. So then what we are doing is we are using again the tooth that we mirrored as a guide to basically make an imprint of the contour of the root. So this is very easy. You just go with a sculpt tool and you create that contour. You basically map the section of the root. Of course, you can also do like Eric showed you with extracting the real root. But here I want to relate to a future root, first of all. And second of all, I'm showing you again, this I find it to be now, because we've done both ways, a bit faster in terms of practical use. So after you get that contour, the actual extraction, the outcome of an extraction for us is an alveola. So I need an alveola basically here. I can create a digital alveola. You just take that section that you marked and you pull it and you create like an alveola or a root. Now everything I'm showing you is basically slowed down in steps, but in terms of time, the planning of such a case to any of our guys would take probably 40 minutes and they don't sweat. I mean 40 minutes to plan everything, the guide and everything I'm going to show, which is quite feasible, specifically the fact that it's not using chair time. So after you do this, every guided software needs the same things. You need the design, and we have it. It's the mirror tooth. We need the extraction side, and we have it. It's the model with the alveola we created digitally. And we need the CBCT to relate to existing bone. And here there are some principles in which you have to consider when you're positioning an implant. I think one of the important things is, again, depth, which is, there are some different opinions there. Maybe, Eric, you want to comment relating to depth, whether 3, 4, 5 to...
In general, I think we stay between 3 and 4. The more you go palatal, the deeper you go. That's normal. 3.5 to 4. The more you go palatal, the deeper you go, because you need to develop the contour of the tooth.
From my point of view, because as I'm the prosthodontist, as I don't have the implant experience, I can tell you from a prosthodontist perspective, the worst thing is that you have an implant not deep enough. If it's at any point deeper, it's manageable, specifically with the implants, with the connections and everything today. I don't find so much of a problem. But if it's not deep enough, then it's a big problem, because then I have to relate everything else to that position. Now, second, of course, we want to get rid of cement. So the axis of the implant, you want to have it in such a way that it's not piercing the buccal, so you want to have it going through the palatal for a screw-retain restoration. Then you have the palatal placement, and then, of course, when you find the position, you already know if you actually need to graft or not, after you, of course, select the implant and everything based on the final tooth. Very important during the planning of an implant is you have to already know what tie base you're going to use the moment you're choosing depth. Because it's a very different scenario if you're going to use a 0.5 tie base, a 1.5 or a 3 millimeter tie base. And generally, we always want to go for a optimally in this system for a 1.5 millimeter tie base. Maybe you want to explain why.
No, if you take a tie base that is too short, your tie base means cementation of a crown on a tie base or any material on a tie base, which will be too close to the bone. We think that 1.5 to 2 millimeter is the minimum distance you need to stay away from the bone with any kind of bonding of a restoration.
And also practically sometimes if you use like a 0.5 millimeter tie base, you will hit the adjacent bone.
Yes.
This also happens. So 3 millimeter tie base you only use in scenarios where you don't have, for some reason, implant stability and you need to go deeper. You cannot, you have to get stability by placing the implant deeper and then you can compensate. But that's a compromise. It's never something you plan. Very important when we do this, there's one thing we cannot control at this step. So we can have the implant position, we can basically export the implant position to generate the restoration and everything, but one thing I don't know, and I cannot know, the index of the implant, which depending on the type of implant you use, you can have 6 or 12 different positions, and this I don't know, which means if I use an anti-rotational tie base, it's a roulette, whether or not I will have a problem with the contacts, and most likely I will. So how do you fix this? For provisional restorations that we design prior to surgery, we use a free rotation tie base, always. Then we will export the position of the implant back to the software in which we designed the restoration. So all of this happens before surgery. And using this, basically at this point we have the alveola, we have the implant position. You can even check, you know, all the components, how they fit. And now we just have to design the abutment and the crown. And as you can see, we only want to copy again. If we make any kind of adjustment, is never on the buckle, never. You can just adjust contact points, but you see on the buckle, the shape is like, you see that interlace of meshes is 100% copy. And then you simply adapt from the root this area that needs to be basically concave, not to put pressure on the tissue. So here you see very clearly, after you have all of these components, then you can just go back and the actual surgery will be just a sequence of steps, but you have everything prepared. So you take the guide, place the implant, you can see the position of the implant. This is a surgery done by my father, and this is one example of the same. I will show you also a mistake we did. Specifically the one that Eric mentioned, which again coming from another side with the same mindset. Because what happened is, and you were very right, some of the things, most of the mistakes we do is because we don't ask ourselves why we do certain things. And I was always pushing my father, who, you know, I was the prosthodontist, he was the surgeon in this case, and I was always telling him, make a soft tissue graft, and we need, as a prosthodontist, you always like to have tissue to play with. So I pushed him to do a soft tissue graft because that's the normal thing to do. That's what everybody says that it's mandatory to do. So we made a soft tissue graft, the BIOS and everything, and then just screw in the restoration. As you can see, this restoration is a mirror of the other tooth, and this is how it looks basically on a video. After you extract the tooth, I think it's very comfortable for any surgeon to start with these components on the table. You have the guide, which gives you the implant position, and then you have a final restoration, which is on a free rotation tie base that you know you're not going to have problems with when you are going to screw it in. So basically the same sequence that Eric showed. You're drilling the implant, placing the implant again. You can do all of this guided, and after that you have the graft harvesting from the pellet. I will speed up a little bit. So we have a generous graft here. And I repeat, I always like to have, every prosthodontist likes to have tissue to play with. Tissue, I mean, it's always comfortable when you have enough tissue, when you have enough depth, because then you can do anything. But this is again the thinking that we had in analog, because we have the right things to sculpt, to adapt. Again, this is the mindset. And then here we have the preparing the graft site. You can see very nice, this is something we learned from Eric. Always you can prepare a nice zenith in the graft, so you can sculpt it a little bit that it suits better the graft site. And then basically positioning the graft. So all of the steps, which are pretty much, you know, like the ones that we know from all sides. And then the last part, after we do all this, with the BIOS and everything, you have the actual screw-in of the provisional. And the provisional, again, it's copying the profile which we design in advance digitally. Now, one thing this does, it first of all makes the surgery very, again, guided, predictable, and easy, because you have all components. You're just following a sequence, and everything, it's nicely planned in advance. This is how it looks immediately after, and when it starts to heal, what do you see? The same problem that Eric showed you. Do you see the volume that we start to have? And when we take it out again, it looks very nice. I'm very happy that I have a lot of volume, but it's too much volume. And this didn't happen in the past. I mean, in the past, when we did this in analog and we did the same graft, we had shrinkage. And then we never ended up with this amount of volume. I mean, this wasn't expected because this is how we've done it for years. Anyways, then we go back, and now all we have to do is, again, take a physical scan body. For the first time, we need a physical scan body to map the position of the implant. And then we go back to the model. Simply, we're changing the component to being an anti-rotational one, and you can see how easy it is now to design, because you have the alveola, which is only, you need to copy that, so you just take the line and position it in the transmucosal area. And then basically we're gonna mill it. And again, very important is the yellow anodized component, not specifically in this case because tissue here is very thin, very thick, but if the tissue is thin, if this component would be gray, you would have a dark area in the tooth. And many times you see people that are not really careful when they polish this, and they take out the yellow from the component, and then you have a problem in the color of the tissue. And then the last part is the design of the crown, as you can see here. So all of the things, once you do it in a certain way, and especially on data, it's very, very, let's say, clean. You know exactly how to control every step. And I just want to show you now that after we mill, again, the restoration, and this is simply staining. So it's a monolithic Empress crown on zirconia abutment. And let's take a look what happens in the mouth. Look at the tissue. You see the amount of tissue we have. And if you compare it to the crown, you see how my crown really is, how deep it goes because of the volume of the tissue. So this is the same mistake Eric was talking about. And of course it's manageable. But now we start to understand why this is happening. In analog, the same case would not have this. Why? Because in analog, what you have compared to digital, you have a lot of steps of adjusting. Now the tissue knows to adjust only in one way, by shrinkage. So every time you adjust something, there will be a shrinkage. Now if you multiply that with a lot of steps, eventually you will have shrinkage. This is basically also the same concept behind like a PET, partial extraction technique and all that. You preserve and you adjust less. And then you need less tissue to make up for it. So again, it's all about this fact. This gives us powerful tools, because once you control the morphology and once you control the flow, there are very little things you will adjust. And then we realize that the tissue behaves differently. Particularly, the number of adjustments results in a number of shrinkage, which we have less. And this is how it looks right now. It's still at 8 weeks, so we don't have a maturation. We need to wait for that before we're gonna adjust it. But it's nice to show, I believe, this part that basically, remember, the one variable that remains in all this digital environment is the organic one, specifically tissue. Tissue responds to adjustments. Analog means a lot of adjustments, digital means very little adjustments. So maybe it's time that we think different also in terms of tissue management in the future here. So I will...
But I think, Florin, we don't have the time anymore to show the last case. We only have 10 minutes. So.
Oh, you can go fast.
Okay, let's try fast then. This summarizes everything basically, because this is something we did some time ago with a team in Timișoara, and there's many things you can see. It's basically a combination of all the things that we have been showing you before. But the only thing is now we're going to go fully digital. And for me it was a very nice experience, because this lady, a friend of mine, restored her 25 years before. She came in and she said the left central is disturbing me because of the color of the tissue. She has pain on the left canine. There was a crack after we redid the endo we saw. And the lateral has a problem of positioning. You will see it immediately. So now these cases, we treat them completely digital, which means that we are going to restore, like I already showed you, everything according to the horizontal line. Do you have this here? To the horizontal line and the vertical line. We get all the information, like Florin said, the X-rays, DICOM files, STL files, and we will start to evaluate intraorally. She had orthognathic surgery 20 years before we saw her now. Not like Puyu, not like yours, very bad. Because, and I think also I see a lot of relapse. I think the surgeon needs to guide the orthognathic surgery, need to control. Not anymore, no. At that time, yes, because she had advancement of the chin. Didn't work really nicely. But anyway, what Florin did with this team in Timișoara, and it's still in beta version, but it's helping me a lot. It's a way to communicate and to send information and to keep it somewhere, but not on an external drive. Now, before I had like one account Dropbox with this one account Dropbox with this one. It didn't work. So they found a system where I can add, like you see here, pictures into a Smile Cloud. It's called Smile Cloud. We can add STL files. We can add anything. And we can start to communicate with the team in Timișoara. So the STL file, the DICOM files, and all the clinical pictures. Another part of the system is that I can make a presentation of what I want. Maybe I have to click, yes. So I put the face there of the patient, and we can start to get the information like in a keynote format, but much faster and much better. We can start to design in 2D, and this 2D thing, we will translate it into a 3D. We can calibrate, as you can see. It's an unbelievable tool for me to communicate. And I think that is what is missing in order to be communicating between different disciplines in dentistry and between different parts of the team, as well from dental technician to prosthodontist, as from surgeon to prosthodontist. It doesn't matter. I think communication is very, very important. So then I ask Lenu to design. She will send me something back. I will print out, and I can print out in two ways, as you can see. I can print out the ideal position of the future crowns, or I can do it on top of the old restorations. As you saw in Florin's lectures, and as he told you, there's only 6% if we have 3 millimeters of difference, there's 6% in scaling. So that's not a big issue anymore. So now we try in a mock-up from the printed model. If you want to show it to the patient without touching the teeth that she has, you just paint it black, take some pictures of the face, and she will understand where you're going. It's like to get a compliant patient, motivation of the patient to get a compliant patient. Take some pictures, show her. I removed the old restorations. Of course, you can do better. Cementation, 20 years was not the same as what we are doing today. But let me show you now, because there's big discussion. I like to keep a tooth as long as possible. Really, I think the best environment still today for soft tissue and for bone is always the natural tooth, always. I still make bridges of 12 units on on 2 canines, 2 molars. We did it 30 years ago. They're still there after 25, 30 years. Implants, I only use them if it's really necessary. Now you have to take into account the wishes of the patient. This central on the left side is very dark. You can graft on top, but it's already prominent. You can try to bleach, but we are placing a lot of implants in teeth that have been bleached internally. The canine, how much substrate is left of the natural tooth? If you want to get some canine guidance, is it okay? The lateral position. If I want to make a nice lateral, I need to do orthodontic treatment. I need to mesialize the lateral. So there's a lot of issues. Anyway, I'm going to try now the mock-up that you just saw on the right side. So we motivated the patient. So now we will use the one that she made on the right side of the screen before, like a real 3D positioning. So we prep. Before I extract, I prep. I want to see where I go. I crown lengthen. Basically, I don't care if I do the crown lengthening now and the osseous after, or if I do first the osseous and then make the final crowns. You can do any way you want.
What is important is that both mock-ups are from the same library, so you see the shapes are the same.
Yes. It's only 3D different position. And that's something I had to adapt to in the beginning. Now, take the final impression. We're going to mill a provisional bridge. What I have to tell you is I was used to make Luxatemp bridges, provisional bridges. You know as well as I know that if you have a full arch bridge and you start to remove it in order to do the surgery, eventually something will break. Something will break, and you have to do again. It takes a lot of time. These milled bridges, I can hammer them, they don't break. So it's a huge advantage of strength. And it's homogeneous material. As Florin said, these retraction cords, they are different. I normally do like a full arch with the second cord removal. I scan, and then my assistant will prepare, and I will take an analog impression with the same retraction cord. And that's very, very important, I think. It's just clinically working very, very well. So that's the occlusal view, provisional bridge in place. Now we will go for the implant placement extraction and 5 implants in the upper. Now, as you can see, this is the issue. How are you going to guide your implant now? Because one central, as you saw on the occlusal, is completely out. The lateral is too much to the distal. So how are you going to relate everything now? You're going to have to do it digitally. You're going to have to plan it. You know the final position of the tooth. You will need to know where you're going to go with the left central of the patient, and you're going to start to work on the model. Look at the left central. Let me go back one, sorry. Look at the left central. What is this? Is these old black posts. If I want to ask the endodontist to remove it, if they are bonded well, it's very difficult. There's not going to be a lot of substrate left. The canine is bad condition. It looks nice, but it's very bad because there's no ferrulum, there's no buccal support, no palatal support. So it's up to you now to decide. I think personally, for the central and the lateral, I'm better off with an implant. Much better off in the end. Not only for color, but also position. For the canine, you can try, but if you have a fracture of the canine after 2 years, you can start all over again. So sometimes it's about decision making and experience and intuition. So the same kind of surgical guides, not difficult to make. extract. Now I started to try different things. Let me go back one. Start to try different things. What is different? What do you prefer to use now? Normal healing abutments, or do you prefer to use an individualized healing abutment with the form of the root? Or are you going to use a tie base and put some flow in the extraction socket? Many options, many options. For the central, I want the tissue to come in. I want it to resorb, so I'm not going to place a connective tissue graft and I'm not going to place bone. But I'm going to guide the tissue in the exact right position. How do I do it? Digitally. We design something completely differently now. Let me go on and you will understand. So guided surgery, placing this. So I placed the implant with a guide, also 2 molars. And then for the central, we made we used a provisional cylinder, added some flowable composite. That's one way to go. It's very inexpensive. You can do basically the same from your DICOM file, or you can do the same from Florin's file when they start to remodel the tissue on the digital file. So this is pretty standard. You start to understand now what we are doing. And look at this now. Either you use the root form and the DICOM, and you adjust it on the tooth. This tooth is too buccal, so you can start now to adjust on the digital file. So this allows you to predict soft tissue shrinkage. We are used, as I said, to think in habits. One habit means I'm going to graft automatically. No, don't think like this. If you copy the root, you don't need a graft. How do you make tissue shrink? No graft, no bone substitute. But you need to keep the tissue in place. How do you keep it in place? Just by guiding it digitally. So that's a nice thing to do. These are abutments that are milled by the company. They're not expensive. They're cheap. And they come from the DICOM file. They still work with DICOM files. In Timisoara, they work with different files. You don't need a DICOM file to do it. You can do it in a different way. So this is after surgery. As you see, on the central, we kept it in. 2 healing abutments for the lateral and canine. Provisional bridge goes in place. Healing after 8 weeks. In general, we wait 8 weeks. I wait 8 weeks. I don't want to wait more. Not necessary. I can play with the tissue now. We can play digitally with the tissue. My implant is integrated, and I want my final restorations after 8 to 10 weeks. This, I think, is important. Because still, as Florin said in the beginning, from a working time perspective and from a financial perspective, digital is more expensive than analog. And one of the reasons is what he explained to you about models. If people show you on social media that they can work fully digital, I don't believe it. I cannot. It's very difficult for me to believe.
The bottom line is that, as you understand digital, if you use it in a smart way, it should give you something, and it should give you the fact that less adjustments and less time. But not every step in digital right now gives you that.
Yes.
Because this one, for example, takes more than the whole case to do, like the model. And then it's, again, doesn't make sense. At this point, not yet. The word is not yet.
Yes, not yet. It will change, and it will change very fast. Can be 6 months, can be a little bit more. So now we are going to go for the finals. I send the file to Timisoara. They start to work on the final restorations, which is all guided by what you just showed in the previous case. It's like superimposing layers. The layer of the impression, the digital impression coping, together with the layer of the initial before extraction, you start to reshape. You can measure the resorption that you got. There's so much you can do. It's unbelievable, the possibilities. Milling, sintering, and then making the abutments for the restorations. Now, what you need to understand is, and there is no research about it, is that you are bonding something to a tie base. So we don't know yet how it will be after 10 years, after cycling, what will happen with the cement. What happens with the cells? Are they going to jump the cement gap or no? Is there going to be any kind of attachment more coronal than the cementation space? We don't know. There's literature enough now to say that we really don't know what's going to happen, and we need to be careful. I believe much more in a click system than a cemented system. A cemented system, for example, your technician needs to cement. How does he cement? He cements on the model for the contact point position. If he cements on the model but it doesn't tighten the conical connection, you have a problem intraorally because of the vertical positioning. So there's many, many things that you need to understand. Color, Florin mentioned. There's a study now for 2016 from the group from Geneva, or yeah, Swiss group, telling you that we tried it also a long time already ago. Pink is not nice for the color of the tissue. Pink metal. Gray metal is not nice for the color of the tissue. Yellow and zirconia, white, is the best for the tissue. There's no impact on the color of the tissue whenever the tissue is 3 millimeters thick. But where do you have 3 millimeters thick? Where the crown meets the abutment, certainly you don't have this thickness. We try in the abutment, and you will see this one, I didn't copy the root, I didn't do anything. It's just digital design. Look now what's going to happen. This is the one I made with my flow. I'm going to replace it with the abutment that came from Timișoara, from Joanna. And you don't see tissue going up or down. It's just very predictable, very, very predictable. This one has been designed according to the shrinkage that we expected. And now I have symmetry in gum thickness and gum levels. These restorations came back. We bond them to the tie bases, and look at this now. And I think this picture, let me go back one, this picture really is for me very, very important, because basically what happened is like what always happens. The guys were in the lab last day. Look at the lateral. It fell and it broke. But it takes you 10 minutes to mill exactly the same form again. And I don't even want to get into a discussion what is best analog or digital. Not at all. We are working analog since many, many years, 10, 50 years maybe. And there will always be a space for analog. But if you take best from both sides, it's going to be very nice clinically to work in dentistry. I think I envy the young generation now, because there's so much you can do. But you have to take best from both worlds. There's not one way to go. There's not only digital or only analog. It's a combination of everything. So final restorations, you place them, and again, even in digital, they need to understand about soft tissue maturation. Don't close the space. Like Florin said, if you want to bring tissue up, for example, like on the lateral, take a conical tooth, take a triangular tooth form. Don't close the space, because this is going to mature. And maturation means this. This is, I don't know, I think it's monolithic, full contour, stained, very slightly stained and polished. That's it. I need my analog model, my plaster model, to check the contact points. There's no way around, at least not in our office. So this is 3 days. This is the maturation. Look at the difference. In the beginning, let me go back one. In the beginning there, I thought, I need orthodontic forced eruption to get this tissue back. What was the problem? What was the mistake I made? I didn't look at the cone beam or a panoramic enough, probably, because it's just the distance of the roots between central and lateral. If there's too much space, you never get a triangle back. You bring the space, you reduce the space with the implant and the crown, tissue comes back very, very nicely. Can we do better? Analog. My best technicians for sure can do better. But not 100 cases on 100. Is not predictable all the time. Machine for me is much more predictable. Lower ones, look at this, we bonded the lowers in that case. She had orthodontic treatment. Maturation of the tissue, don't close the space. If you close the space, you change the form. I think that's the main message. It's an Empress multi-layer block. It's a very nice material. X-rays, look at the tissue. I unscrewed. I shouldn't unscrew, it's just for the picture. But look, the bio is still there. Does it mean it's recent? No. Just what is there is there. It doesn't matter. Some people ask me, why don't you use socket shield technique? Because why would I use it if I can do it like this? It's a risk. It's a little bit risky. Do I do it? Yes, I do it. If you have a very long canine, very fragile to extract, maybe you leave the socket shield. There is a place for every kind of treatment in modern dentistry. No different concept for premolar or molar, exactly the same. Exactly the same, try to be screw retained and predictable. So we change the patient from here to here in a very predictable way, maturation, and I think I have the face now. And this looks very okay, no? So I had to go a little bit faster in the end, but what I think we tried to do, and I hope you appreciated it, is to show you what I've been doing as an old practitioner since 35 years, and how I found a lot of interest in what they are doing, because it facilitates everything and it makes me much more predictable. So it's old school dentistry, younger, pragmatic, skilled, and clever
all
people.
concepts are analog. This is one thing we have to remember.
Yes.
All the concepts are analog, and then we should only pick the digital concepts, which are the digital tools, basically, not concepts, that are shortcuts to what we need. Not everything that's digital flies, not yet. And that's why you always have to question, like we do all the time. Why do we do this? Why do we do that?
And is it worth doing it?
Yeah.
I think it's worth doing it, and I would like to thank you. Florin is I told you I have a lot of young dentists coming to my office from Brazil, from Colombia, from anywhere, from Bulgaria. But he's somebody who thinks a little bit different, and I would like to thank you for the years of support. Huh? So thank you very much, all of you.
Thank you, Dr. Van Dooren. Thank you, Dr. Cofar, for your very interesting presentation. A lot of information, and for many of us, a lot of ideas for the future. If someone have a question, feel free to ask, please. If it's possible, we have a question. Yes, Dr. Ionescu.
Please don't go. I have a quick question for everybody. Stop going out. Stop, please. So I have a question for the audience and for the two very, very high-end lecturers that we just saw. Which of you are using both, or at least a little digital in your everyday practice, workflow? Please raise your hands. How many of you? Like 20%? 5%, okay. And now I have a question which might be very interesting for the rest of the percentage. Can you just answer for a very, very quick question? The learning curve, if we want to switch from analog to digital, both in prosthetic and surgery, in our everyday practice, how long it would minimally take for us? Thank you.
If you're between 40 and 60 years old, 2 years. If you're between 20 and 40, probably 6 months. I mean, we were not used to, and it took me 2 years basically to understand the advantages. But I think all the young people, you will be much, much faster.
I will tell you something which we spoke also in the break. The hardest thing in learning is not learning, is unlearning. And the most difficult time we had in implementing all of these things is people that don't want to give up what they are comfortable with. And sometimes to do something completely new, the first most fearful step is letting go of something that you've done for a long time. So it's all a question of mindset, I believe, beyond everything else, because technology is designed to be intuitive, but it's just about the mindset, I believe. Thank you.
Thank you very much.